Well, it fills a very important gap in our knowledge. We know with stable heart failure of any type of ejection fraction based on the EMPEROR preserved and EMPEROR reduced studies, as well as the DAPA-HF studies, we know that these drugs reduce mortality or improve quality of life, if we look at those in the round. But what we don't know is what happens when people are acutely decompensated, and this is where EMPULSE comes in. Okay, so it's a randomized control study. These were patients who came in acutely unwell with acute heart failure. Their entry came in on an anti-proBNP cutoff rather than an echo finding, and some clinical features. They were once stabilized. They were randomized to 10 milligrams of empagliflozin or placebo on day 2 through to day 5. So, as all of these studies, there's always a composite outcome, and indeed that was positive. But the actual individual components of that composite were all actually in favour of empagliflozin, and that included time to cardiovascular death, heart failure events, the time to heart failure events, and quality of life. So empagliflozin essentially delayed mortality, it delayed heart failure events, improved quality of life, and actually reduced the total number of heart failure events. Well, interesting really, and it builds on some of the evidence we already know. So first of all, there was much fewer adverse events in people taking empagliflozin rather than placebo. I think one thing which caught my eye was acute kidney injury. Again, we saw a reduction in that, and we've seen that consistently throughout all the SGLT2 inhibitor trials, whether you're looking at people with diabetes, people with kidney disease, or people with heart failure. But because this is the first time we're looking at an acutely unwell patient with heart failure, acute heart failure, decompensated acute heart failure, I think this is a particularly vulnerable group, and it was great to see them benefit from the renal protective effects. Yeah, and of course, diabetic ketoacidosis, because this study did have people living with diabetes as well as people who didn't have diabetes, and actually it was reassuring there were no cases of diabetic ketoacidosis. In terms of what it means to me as a primary care clinician, I think if you've got someone who's acutely decompensating, I would try to manage them. If I can manage them at home, I would do so, and I would maintain their SGLT2 inhibitor. If they're so unwell that I think they need closer monitoring, I would admit them to hospital, and hopefully the hospital would continue that medication, because we know by the times of the follow-up of 90 days, those people in the study who weren't on empagliflozin actually had these excessive adverse events, including mortality. So it does raise the question that if we stop these agents in acute phase, are we actually going to do more harm than good? So for me, that's the big question. Just keep going, and if they're so unwell that you think they need to be closely monitored, well, admit them to hospital so they are indeed closely monitored.